So what is peripheral vascular disease? I am coming for the peripheral arterial disease first. So what is peripheral arterial disease? Classically, peripheral arterial disease was defined as intermittent claudication and ankle brachial pressure index less than 0.9. Okay? This is the classical intermittent claudications and the ankle brachial pressure index less than 0.9. This is the peripheral arterial disease. I am not the peripheral vascular disease, because peripheral vascular disease means artery and vein both, also the lymphatic system. So it is the peripheral arterial disease. So it is the patient will come to you with the complaint that, sir, I have the intermittent claudications. As a clinician, you will see what is his ankle brachial pressure index. And you will be finding that if it is less than 0.9, 0.9 actually, so that is less than 1 actually. So it is, you will diagnose that it is some or we expect that is they have the peripheral vascular insufficiency. Okay. So now you have to know how you diagnose them. There are so many objectives or so many investigations you can do. So what are the investigations you will do to have the proper diagnosis? First, the gold standard of investigation is the arteriography. Arteriography, that is the angiography. Angiography you will be doing and you will finding so many things. There may be, I am coming later words, there may be sudden cutoff, there may be collateral circulation, that is the corkscrew. Okay, these are the findings you will be getting in the arteriography or angiography. But as angiography is an invasive procedure, it has some complications. Like you are putting a dye, suppose high effect, that is sodium diethioxide. So you are putting this dye. So there will be, you have to see the renal function in advance. So if the patient is, suppose creatinine is 1.92 like that, you can do these things. Because the dye will be excreted through the kidney, isn't it? So it is invasive procedures, and as it is invasive procedures, it will definitely have some complications. And local complications like there will be some embolism, some peripheral digit, maybe necrosis like that. So peripheral arterial disease, the arteriography has been replaced by the USG duplex scan. So what is USG duplex scan? In real mode, you know, that is the B mode where in general what we are doing, that is the ultrasonography, that is the B mode. What is B mode doing here? Now in B mode, we will find the anatomy of the artery. The artery is going from here to here. And in addition to B mode, we are adding the Doppler one. So Doppler one, what it will do? The B mode will ultrasonography give you the anatomy. You can see, yeah, blood is flowing there. And Doppler mode, in addition, as there is RBC, you know, and Doppler mode, they will pick up the sounds of arterial flow. Okay, so that is, in normal, what you have, first 3 and second, 3 sounds are there. Suppose in normal blood flow, there will be, when I am adding the Doppler, there will be 3 arterial sounds. But in case of any obstruction, suppose there is obstruction of arterial flow, there will be turbulence. Normally you will get the 3 sounds. When there is obstruction, you are getting the turbulence, and when there is absent of flow, there will be getting no sounds. So these are called the Doppler shift. Got it or not? Okay. And what else are there? After that, you can do that. Though we are not doing all these things, xenon you can do, or technetium-99 scan you can do. RSA plethysmography. What is plethysmography? It is a segmental arterial pressure. All these things you can do. So after this thing, you will be coming to the patient itself. So what are the local symptoms you can ask to the patients. So what will be symptoms? As I have shown, that is the intermittent claudication. There will be findings of necrosis. There will be findings of gangrene. Patient may complain to you that there will be burning sensation. There will be rest pain, all these things are there. It will be taught in the bedside clinic, though I am touching here. The thing is that there will be signs. What are the signs of necrosis? What are the signs of necrosis? Signs of necrosis that the thin shiny skin, there are loss of hairs, wasting of the muscles, and obviously there will be pain. Okay? So, and when necrosis will be occur? When the arterial ankle brachial index between the 0.9 and 0.5, got it or not? At this point there will be some points of ischemia. Okay. So, ischemia will be between the 0.9 and 0.5, and signs of ischemia are these I have been saying, that is the loss of hair, loss of subcutaneous fat, loss of muscles guts, and definitely there will be pain. Because before this ischemia, already intermediate claudication has come to you. Got my point? So now, what will happen in next phase? You can do the examination of the patient. All these things will come. So what are the causes of these things? What are the causes of these things? So if it affects the large vessels, it will be mainly cardiogenic one. So what are the cardiogenic? Mainly the atherosclerotic and the embolic. And what are the small and medium sized vessels? I will be coming later, and I think you have heard the name. What are these? This is the again atherosclerotic. This is the Burgess disease, you have heard. This is the Raynaud's, okay? And this is the some other condition like maybe embolism, okay? All these things can happen. So this is small and medium size. So I am stick to the necrosis only. I am not coming to the gangrene. That my ABPI is still now between the 0.9 and 0.5. Got it? So this is a necrotic part. And what are the causes I have already mentioned? Large and medium size, large vessels and medium vessels, and the small and medium vessels. Large and medium is the atherosclerotic, embolic. Small and medium, that is the Burgess, Raynaud's, any other arteritis, embolism, all these things. Got it? Now, how you will differentiate all these cases? You have to go a differential diagnosis like that. So, suppose you are going to the cardiogenic first, atherosclerotic. I think you will be knowing the atherosclerotism only seen in the elderly patients. Okay, an elderly patient, you have to do the investigations like lipid profile, blood urea nitrogen, or urea creatinine, all these things. And you can do even the X-rays. In X-rays, you can find the arterial, even what are the layers of the artery? Adventitia, media, and intima. So there will be median, arterial median wall calcification. So that is called monkey work sclerosis. You have heard this thing, isn't it? So that is the senile. After that is the Burgess. So what is Burgess disease? What is Burgess disease? Burgess disease is seen in young male, suppose 20 to 40 years of old, mainly male patients, but it can happen to also female. So what is the Burgess definition is? Non-atherosclerotic, migratory, inflammatory disorders. Got it? Non-atherosclerotic, migratory, inflammatory disorders of small and medium sized arteries. Mainly affects the lower limb, but upper limbs may also be involved. Till date, cause is unknown or idiopathic, but there is a relation to tobacco. Tobacco has been thought it is a causative factor of having the Burgess disease, but still it is not authenticated or it is not been proved. So, cause by and large is idiopathic. So, what will be the pathogenetic feature of this thing? It not only involves the artery, it involves the artery, veins, and the neighboring nerve structure also. If you, it is a basically I have told the inflammatory disorders. Now question will come, what is the inflammation? There is local inflammations or systemic inflammations. It is a systemic inflammation. Why? There will be migrating superficial thrombophlebitis. The migrating thrombophlebitis is seen also in what thing? Visceral carcinoma, particularly the pancreatic carcinoma, isn't it? So it is a systemic inflammation. Got it? It is not a localized inflammation, it is a systemic inflammation. So why? If anybody asks you why, now there is some superficial migrating thrombophlebitis. Now if you cut the sections of the particular term, take some punch and have under microscope, there will be localized microabscess. It has been finding that localized microabscess, there will be polymorph nuclear infiltration, there will be lymphocytosis and the mononuclear inflammation, and there will be multinucleated giant cells. So all these things come in conclusion that there is a inflammatory process of unknown etiology. I am again telling it is an unknown etiology. I don't know why it happens. Nobody knows. Cause is idiopathic. Correlation has been found with the tobacco. Got it? So this is the thing. So what will investigate? Again, all this investigation you can do. That is the arteriography is the gold standard, but we will be doing the ultrasound duplex scan. Okay. In arteriography, what you will find? The corkscrew appearance of, that is the circulation, collateral circulations, findings of collateral circulations, that is the corkscrew one. Okay. And again you can do the ultrasound duplex scans. So this is the Barger disease. Now Barger disease, what patient will come to, what complaint? Again you know the intermittent claudications. Intermittent claudications is the first and foremost complaint of the patient. So when intermittent claudications come to you, that means his ankle brachial pressure index is how much? Between the 0.9 and 0.5. Okay. So what you will do? Under local examination, what you will find? I have already mentioned, on local examination you will find the local area is cold and there will be no hairs, subcutaneous fat is lost, shiny skin, and the girth of the muscles of the lower limb, definitely that will be diminished. Got my point? I am not coming to this thing that the bedside clinics. What is intermittent claudications? You know. What is intermittent claudications? When patient starts work, after going to some distance, he will feel pain. Why there will be pain? Why there will be pain? No, as demand increasing, when patient is walking, there is contraction of the muscles. So it needs much more oxygen. But as there is compromising the circulation, the blood is not adequately reaching there. That is the oxygenated blood. So there is, what is happening? I mentioned in the, I think I mentioned in previous class, so some other classes I think. So what is happening there? Anaerobic process is going on. Yes, definitely P factor is there, pain factor, and he is getting the pain. Okay. So, and there is claudication, you know, grade 1, grade 2, grade 3, I am not mentioning here. That will be treated in the bedside clinic. So, what will be the treatment of Barger disease? What is the treatment of Barger disease? First and foremost is the conservative management. Conservative management, the exercise that is there. Again, there is a Barger exercise. You will ask the patient to walk, okay, and quit the smoking. First and foremost thing is the smoking. Okay. Though other some vasodilator has been tried, but in most of the books it has been written or most of the literature has been proved that there is no role of the vasodilators. Okay. So if patient quits smoking, almost 50% of the patient or more, even more greater in amount, that is the percentage, it remits. If patient stops smoking, almost the disease process is remits. Okay. After that, if he continues, then definitely you have to do think for other thing. That is the lumbar sympathectomy or something other amputation like that. I am coming to the gangrene now. So what is gangrene? What is gangrene? Gangrene is macroscopic tissue death. Cause is almost same. What I have already, it is the atherosclerosis, but all these things can go to gangrene. So gangrene is macroscopic tissue death, isn't it? So what you will investigate are what are the causes? That is the atherosclerotic, diabetic. Again, diabetes is associated with atherosclerosis, and the Burgess. Again, embolism or cardiac, others that is a cardiac arrhythmia, whatever. But if it is embolism or direct arterial injury, there will be acute onset. What are the signs or whatever is the symptoms of gangrene? Symptoms of gangrene: loss of temperature, that is no loss of pain, no loss of sensation, and no loss of function. These are the all signs of gangrene. Now, what will be treatment of the gangrene? The main aim of a surgeon is to what? Preservation of the foot. Preservation of the foot, isn't it? So, you have to know how much you have to amputate or no need of amputation at all. So, you have to know the demarcation. In dry gangrene, you will be finding a demarcation of line. That is this is the gangrenous part, this is the healing part. In between that, there is a thin layer of or thin line of the granulous tissue. Okay. So, gangrene, what you will do in treatment of gangrene? Absolutely dry. You have to keep the part dry. Okay. There is no need of any ointment or like that. Never do. So, it will be dry, and you have to cover the gangrene area, that is the no come insects or that come to this thing, fly or flea. And after that, in some book it has been written that you can give some fan, that is the air, so that it will improve the desiccation process and it will help or this pain. Okay. And there is no need, never ever give the warm compress, I am telling you. Don't give any warm compress. Some book it is written and give warm compress. No, it will increase the gangrenous area. That is, it may be infected or it is increase the gangrenous part and it may need more amputation. Okay, so this is the gangrene. Now, whatever peripheral radiology you have already heard, that is what is Raynaud's disease? Raynaud's disease is that it is again idiopathic disorder. Again, it is an idiopathic disorder. Okay? And in exposure on cold, there will be first thing, there will be spasm of the arterioles. So, there will be blanching of the, usually seen in the females. So, blanching of the pulp or whatever the fingers. Few seconds later, so arteriole is constricted, that is the stage 1. It is the blanching stage. After that, capillary is getting dilated. So, when capillary is getting dilated, you will provide there the deoxygenated blood, isn't it? So, that will be turned to dusky one. So, first thing blanching, then it is dusky. Why it is dusky? Now, there is the deoxygenated blood comes. That is the stage 2. And stage 3 is that again, in the meantime, the arteriole has again regained their lumen, there is reopened their lumen. So, there will be exaggerated rate. Got my point? So, this is the 3 stages, stage 1, stage 2 and stage 3. Cause is again unknown, though there is a neurological correlation has been, some authors or some researchers they are being advocated that there is a neurological correlation. Why? Now, they are telling that if we do cervical sympathectomy, few patients are getting result. Thereby, there is a neurological correlation. By and large, what will be the treatment? Treatment is conservative treatment. Warm, you can give some warm, whatever you say, that is the cover, and nifedipine, this calcium channel blocker, and in some cases lumbar sympathectomy. So it is the Raynaud's disease. Sambuga, I think Raynaud's disease, Raynaud's phenomena of these things have been. And what is Raynaud's syndrome? Raynaud's syndrome is quite different from the Raynaud's disease or Raynaud's phenomena. Raynaud's syndrome is like that. It is also called the vibrating disorder. Though workers who are working with the vibrating machines, it is also called the vibrating disorder. It can occur with the carpal tunnel syndrome. It can occur again with atherosclerotic. And it can occur even with this thing that is some atherosclerotic and some other conditions of the senile disorders. But basically or principally, Raynaud's syndrome is a collagen vascular disease. You have to keep it in your mind. The Raynaud's disease and Raynaud's syndrome. In Raynaud's disease, one thing I forgot to tell you, there will be no superficial necrosis. In Raynaud's disease, whatever I asked previously, there will be no superficial necrosis. But in Raynaud's syndrome, it is a collagen vascular disease. Okay, so there will be association with systemic lupus erythematosus and with the rheumatoid arthritis. Symptoms will be the same. Sometimes pain, all these things can come, and there will be superficial necrosis, that there will be ulcerations can occur with that. Okay. So, treatment again here, calcium channel blocker and the nifedipine I have already mentioned, and you can give some local warmth, all these things, and steroids. Okay. So, these things, and one thing I have forgot to mention you, that is in Burgess disease, never ever give the beta blocker. You write down there. Never ever give the beta blocker in Burgess disease, because it will increase your intermittent claudications. Now, other, though they are rare and they are not important to your class, but that is to your age group, but it is also just a name is there, that is Takayasuga disease. What is Takayasuga disease? Takayasuga disease is again unknown etiology, aortic cut and the great vessels, that is the root of the great vessels are affected. So, in this area there is some arteritis and symptoms some like that, fainting, some decrease in the face muscles or face fat, all these things, vertigo, all these things are occurs. Cause is unknown. And what is acrocyanosis? Acrocyanosis is the deficiency of the blood, there is an oxygenated blood to the skin, particularly to the skin. It can occur to the cutaneous capillaries. These are not getting dilated and they are not providing the proper circulation to the skin. Again, cause is unknown. Nobody knows the cause. Okay. Now, what is thoracic outlet syndrome? These are all peripheral vascular disease. Thoracic outlet syndrome, under this thoracic outlet syndrome, there may be cervical rib, okay? There may be scalenus anticus syndrome, there may be costoclavicular syndrome. All these things comes in the thoracic outlet syndrome. For this thing, diagnostic purpose, even the angiography, you can do the ultrasound duplex scan and some clinical tests like Adson test. It will be mentioned in the bedside clinic. Okay. So, any questions for arterial disease? I will be coming to the venous one. Bolo. Arterial disease, Marquez. Any questions you can tell me? Have any questions? Sorry? ABPI index. What is ankle brachial pressure index? That is the, you have to measure the blood pressure here. You have to measure the blood pressure there. That is the systolic blood pressure. Got it? So, systolic blood pressure which will be raised? Usually ankle or brachial. So, it will be systolic blood pressure is the brachial blood pressure divided by ankle blood. Ankle blood is much more than this thing, So, there will be some like that. Normal is 1 or 1.2. Some books written it is 1, some books written more than 1, and in some book written 1 to 1.4 also. They are called it is normal. I am coming to that. You have to ask a good question. So, that is called ankle brachial pressure index, isn't it? So, ankle brachial pressure index, if it is more than 1.3, that is also dangerous. You are thinking it is higher scale, so it is good. No. That means there is no compression of the arteries. That means there is the calcification of the tunica media. So, in that case, what you will do? What you will have to do? That is the toe brachial index. So, there is a greater toe or some other toes The great toe, the artery that is the artery of the toes, that is the digital arteries, they are not getting the tunica media calcifications. So, if you measure the toe brachial index in much more earlier stage, you will be able to know the peripheral vascular disease, that is the arterial disease. Got my point? Toe brachial index is much more superior to ankle brachial pressure index. Why? Toe brachial, that is the digital arteries, they don't have any medial, that is the tunica media calcification. Got my point? Normal toe brachial index is 0.75. If it is less than 0.65, then there is a chance of peripheral arterial malcirculations. Got my point? Okay. So, it is clear to you. Okay. And another thing is there, though these are not important nowadays, nobody does, Brown's vasomotor index. What is this thing? Temperature of the mouth and temperature of the skin, mouth minus skin, it divided in the mouth. So, if it is more than 3.5, that is the indication of amputation. In some book it is written, these are not important nowadays. Now, I am coming to the venous disorder. As you know, the peripheral vein starts from the foot itself. There is a superficial system and the deep system. The superficial system comes from the digital thing, and they are coming to the great saphenous vein, ultimately draining to the femoral vein, that is the saphenofemoral junction in the foramen oval. Deep vein comes to the same thing, and there is a peroneal vein, soleal vein, and they are coming to the, after passing to the popliteal vein, again to the femoral vein. Okay. So, these are the anatomy. Now, what is the most important to your class is what is DVT, deep venous thrombosis. It is the most clinically important thing. Deep venous thrombosis, again, it is what is the causative factors? There may be stasis, there may be coagulation factor, that is the hypercoagulable state, okay, and injury. What injury? Venous injury. Venous injury means there is the injury of the vascular endothelium. So, in stasis what happens? DVT by and large starts from the soleus venous sinuses. So, soleus venous sinuses, blood is accumulated there, platelet are coming towards in attraction to the vascular endothelium, they are getting activated, coagulable state starts. And number 2 is the hypercoagulable state. Why? In the system finding that there is a protein C, proteinase deficiency, factor VIII laden mutation gene, and the prothrombin gene mutation. These are all actually biochemical thing, molecular level, but you have to write all these things. And again the venous injury, suppose you are doing a pelvic surgery clinically. So, extended position, lithotomy positions, okay, long time going on the gynecological procedure. So, iliac or femoral vein there will be injured. Injured means I am telling again the endothelial injury. So, all these things aggravates the deep venous thrombosis. So, what is that deep venous thrombosis? In acute conditions you have to know that is the swelling of the lower leg, even it will be pitting edema, and what is called phlegmasia alba dolens. You have heard the name. There is only the venous obstruction. There will be edema, and there will be swollen, pitting edema will be there, and it is called phlegmasia alba dolens. Edema is going more and more and more, so there will be, they are giving the pressure to the, as a compartment, leg is a compartment, isn't it? So it is pressure to the arterial system, then it will be a phlegmasia cellular dolens. Cellular dolens means arteries are getting compromised. Got my point? So there will be, initially it was white, now it is dusky due to arterial complications. Now DVT, what will be treatment, what will be the complaint of the patient? Swelling itself and pain may occur. Okay. And what will be the investigations? Again the ultrasound duplex scan is the investigation choice nowadays, though previously it was the venography. It has been replaced by the USG duplex scan. So you can see there is a thrombus, okay, suppose in the iliofemoral junction or upper part of the femoral vein. And what will be the treatment of the, it is most important to you, the treatment of the DVT, deep venous thrombosis. Treatment is, suppose in acute stage, what you will do? Rest of the patient, elevation of, why elevation of the foot? Elevation of, if thrombus is dislodged, when it will go? Thrombus is lighter than the blood. So it will float on the blood, isn't it? So if I stand, the thrombus will go outside. So rest on bed, elevation of foot, and the treatment of the thrombosis process itself. So what will go in that phase? You have to give the fractionated heparin. Dose of the fractionated heparin is 80 units bolus dose. That is the, by and large 5,000 unit bolus dose and 18 unit per kg per hour as a continuous dose. As you are putting the heparin, you have to maintain the partial PTT, that is the partial thromboplastin time. What is normal partial thromboplastin time? 40 to 50. And you have to keep it to 60 to 80. Now after, suppose you are continuing for 4 to 5 days, you are measuring the PTT, calibrating this thing, measuring the PTT, it is come to 80 like that. So you can put the patient to the oral anticoagulant. What is that? Warfarin. By and large, you can start with 2 mg. Few 2 days or 3 days, there will be overlapping between the heparin and the warfarin. Suppose last 2 days, you can give both heparin and the warfarin, and you are measuring the PTT, you are measuring the what? Prothrombin time on INR. Ideal INR should be kept up to 3. When the INR has been come to 3, then we put the patient to warfarin. Okay, 2 mg. And usually it will be continued for 3 months. Okay? So it is the DVT. Now, after DVT, what will happen? The most important thing and most interesting thing to you, the case may come to you. So after DVT, there will be destruction of the valves in the veins. Permanent damage of the valves. So it will cause to venous insufficiency. So what we see in our ward, that is the patient come to us, it is the varicose veins. Got my point? It is nothing but is the venous insufficiency. Chronic venous insufficiency. So the varicose vein comes. Why varicose vein comes? Before that, though some books written and though researchers are written, there is some correlation, the congenital, that is the genetic disorder is there, but by and large, it is seen that by history, they give the history of previous deep venous thrombosis. So deep venous thrombosis causing the destruction of the vein, and there is the chronic venous insufficiency. So varicose vein will comes. Now what is varicose veins? What is varicose veins? You have seen in ward, I think, our clinics. Varicose veins is a elongated, tortuous, dilated lower limbs veins, mainly the great saphenous veins, isn't it? So, the population involved is mainly the main populations, age group again is 20, 40 or 50 like that, and the person who stands for a prolonged time, that is the tram diver, looks like that, they have the mainly the varicose veins. Now, what are the symptoms of varicose veins? What are the symptoms of varicose veins the patient come will live? Bolo? Heaviness, and sometimes there may be dragging pain and extremely fatigueness. Okay, these are the symptoms. So, what will be the investigations? And test will be done in the, again I am telling you, the bedside clinics. All the, colored doublet is the most important thing. Again, venography is the choice, that is the gold standard, but you will do the colored doublet test and the clinical test. So, in clinical test you can find the incompetence, perforator, all these things are there, you know. So, colored doublet, that is the most important things. Again, you can tell also the ultrasound duplex scan. Okay. So, heaviness, discomfort and the extreme tiredness, particularly in the afternoon, that is the whole day work, patient doing whole day work, and in evening is complaining of this thing, feeling these things. Now, again treatment is, what will be the treatment? Initially conservative treatment, that is the graduated stockinets. Okay. What will be the pressure of the stockinets? 20 to 30 millimeter of mercury. Grade 1, grade 2 and grade 3, 20, 30, 40 to 44 like that. Usually we use the up to F2, that is the 40. Okay. And exercise again, patient have to work with the wearing of the stocks, and if does not relieve pain, then there are ways of surgeries. First thing is the saphenofemoral flash ligations, and all the perforators, they are to be ligated. And there is now, what is this thing? Laser surgery, NDIAG lasers you can put them, but NDIAG laser cannot do if it is less than 1 millimeter. So, telangiectasia, you know, that is a superficial capillary, or superficial telangiectasis, this cannot be taken the laser. They have to be taken by the superficial sclerosing agent. And what is the sclerosing agent? Sodium tetradecyl sulfate. Now, what is venous ulcer? In long-standing venous insufficiency, there will be venous ulcer. Venous ulcer is seen in the medial side of the foot, usually at the level of the medial malleolus. Okay? Usually at the level of the medial malleolus. So, if you do the colored doublet test again, you will be able to finding there is almost in all cases there is a perforator, incompetent perforator at the base of the venous ulcers. What is the treatment of the venous ulcers? Again conservative, that is the 3-layer dressings applying the zinc oxide. 3 layers dressings applied the zinc oxide. Also it is called the Unna plaster. You know, in some books it is written Unna, U-N-N-A. Okay. And if needs surgery, then again you have to ligate the communicator, that is the perforator of the base. If doesn't heal, then conservative surgery. Okay? And if any questions to you, we can ask. Almost I am completed the arterial system and the venous system. Now lymphatic system is left. I think it will take another class. Okay?